Good afternoon, everyone. I'm Stephanie Cooper Greenberg, and on behalf of the Greenberg Bladder Cancer Institute, we welcome you for this fascinating program this afternoon on it's called Comparative Oncology, and it's the subject is bladder cancer in dogs. Who knew that was a thing? But it's a big thing, and it's really, really important for research and discovery. We have one of the world's expert veterinarians with us today, Dr. Debbie Knapp, and our own Noah Hahn, professor of oncology. I'll introduce them both in just a few minutes. But first of all, a little housekeeping. And again, thanks for joining us for this hour-long conversation. We encourage questions and we want you to be part of this dialogue. And also, I hope we all learn a lot. I think we will. First of all, as you know, we have a Grand Round series. This is it. And we give a presentation just about every month. We take a little break for the summer. These are recorded and archived on our website. If you Google the Greenberg Bladder Cancer Institute and go to there's a part where you can archive and see the older presentations. They're there for you to take a look at. In addition, we have a women's only educational program based out of Sibley Memorial Hospital, our Johns Hopkins affiliate, for women with bladder cancer. And our next program there is coming up on May 7th from 4 to 5. And that topic this time around will be on the quality of life for bladder cancer patients and palliative care. There's a lot of demystifying to do around palliative care. And we have a fantastic physician based at Sibley to sort of share her views on it and really actually explain what palliative care is. It's not as bad as you think it is. And it's all about quality of life. So that's, mark your calendars, May 7th. In addition, our next program is on May 20th with our own faculty person, Dr. Max Cates, who's one of the experts now in BCG. We all know what that is as a treatment for bladder cancer. And he's going to give a fun talk and an important talk on, quote unquote, what's up with BCG and now the alternatives that have become available in light of many shortages and also some new discoveries. And again, May 20th from 4 to 5 p.m. If you have any questions for us or have any inquiries or want to contact us for any reason in any way, the easiest way is we have an open door policy through email. We have our own email addresses. That helps navigate the giant Hopkins system. So the two email addresses are bladdercancer@jhmi.edu. JHMI stands for Johns Hopkins Medical Institutions.edu. And the other email address for those with interest in upper tract urothelial cancer, it is utuc@jhmi.edu. You can ask us anything. You can ask a question that never got answered or an afterthought. You can ask us about appointments. You can ask us anything on those two email addresses. Our aim is to be a medical home for bladder cancer and upper tract diseases, and also to access care for you easier. It's a hard thing to do these days. So remember, bladdercancer@jhmi.edu. This afternoon, we're so excited to welcome this program that Dr. Hahn and Dr. Knapp have spent a lifetime of scholarship and hard work working on, and it's time to bring it to light because it's really, really fascinating. So it's not, it's sort of like this, a veterinarian and an oncologist, walk into a laboratory and let's see what happens. It's not a joke, but it's a real thing that happens. They'll tell us their story, how they started collaborating. But first, let me introduce Dr. Debbie Knapp. She is professor of comparative oncology at the Purdue University College of Veterinary Medicine, and she's the Dolores McCall Professor of Comparative Oncology. And today's topic is about comparative oncology, a new term, a new field of study that maybe a lot of us didn't know existed. It's really fascinating. She's also the director of the Evan and Sue Whirling Comparative Oncology Research Center at Purdue. She did her undergrad at NC State, her doctorate of veterinary medicine at Auburn, and a master's and a residency at Purdue. She's done postdoc research efforts in cancer pharmacology and tumor immunology, and she joined the Purdue faculty in 1990. She studied bladder cancer in canines for over 3 decades and how it serves as a relevant model for humans, known nationally and internationally for this. She's on the senior leadership team and the NCI, National Cancer Institute designated Purdue University Institute for Cancer Research. And she chairs the steering committee for the NCI's Integrated Canine Data Commons and serves on the steering committee for the NCI-funded Pre-Medical Cancer Immunotherapy Network for Canine Trials. That's all really, really huge and important. Our very own Noah Hahn lives and makes his home at the Johns Hopkins Greenberg Bladder Cancer Institute and at the Sidney Kimmel Cancer Center at Hopkins. He's spoken with us many times. Noah is a practicing medical oncologist. He cares for patients with bladder cancer and also collaborates in his multidisciplinary clinic with Dr. Cates. He's currently conducting clinical trials. Noah is arguably one of the best clinical trialists in the world to test new therapies for bladder cancer, including those for early stage bladder cancer. He earned his MD from Indiana University, and he completed his residency in internal medicine at Duke and performed a fellowship in medical oncology at Indiana University School of Medicine. He joined our faculty in 2014, and we are blessed to have him. He's co-director of the Bladder Cancer Institute, and along with Dr. Cates, as I mentioned, has the first uh, and unique multidisciplinary clinic for non-muscle invasive bladder cancer. And he's a gem, and we love him. And now we're going to bring Dr. Knapp and Dr. Hahn to have some slides, but more conversation about what this field is, what it means for humans and for dogs. And also, we welcome your questions. So please put them in the chat, and I will be your moderator and bring forth your questions. So without further ado, thank you all for being here, and let's hear this fascinating conversation. And while we're waiting, once again, the next presentation is May 20th with Dr. Cates on BCG. So we're getting our speakers. Here they are. Here's Noah. And there's Dr. Knapp. Thank you for joining us. Before we start the presentation, I always am fascinated by your journeys and also in awe of the scholarship and the dedication. Studying bladder cancer in dogs for 3 decades, holy cow, that's a long time. But I wanted to ask Dr. Knapp first, how on earth did you manage to settle or focus on bladder cancer in dogs, which is somewhat obscure to us outsiders? How did that happen? And it's just fascinating. How did that come to be? And the second part of the question, you and Noah have collaborated for a long, long time. And how did that happen, even though now you're at different institutions? So, Dr. Knapp, welcome. And please tell us your story of discovery and why bladder cancer and why dogs.
Thanks, Stephanie, and I really appreciate the kind introduction and the opportunity to join this panel. The journey to dog bladder cancer was certainly not a direct one. I sometimes admit it was almost an accident. I was planning to be a small animal veterinary practitioner, primary care, and then that merged into wanting to be a veterinary internist, and then that merged into being a veterinary medical oncologist. And along the way, I had the opportunity to do research to understand the anti-tumor effects of non-steroidal anti-inflammatory drugs. And this came out of some observations we had made in dogs, totally unexpectedly. But essentially, we did an all-comers trial of a non-steroidal anti-inflammatory drug in dogs with many, many different types of cancers. And some of the best responders, there were two groups that had particularly good responses. One was those with invasive bladder cancer, urothelial carcinoma, and the other was those with oral squamous cell carcinoma. So we were going to decide which cancer to move further along in this exploration. And we picked bladder cancer because there has and still is a huge need in dogs. There's a huge need in people the canine disease and the human cancer are so similar that we felt like what we learned from dogs could be of value to human bladder cancer patients. And so we went into it thinking this would be a relatively short-term venture, and it's turned into about 3 decades. So it's just every time, every study we do leads to more studies and more opportunities. And we've been very, very grateful to work with Noah. We began working together when he was at Indiana University, and he actually wrote the grant, obtained funding for epigenetic therapy in dogs that we did. And he would come up to Purdue and we would show him some of the dogs in the trial, and we'd go over the data and compare it to what was known in humans. And so it's been really our good fortune to work with him. Just a phenomenal researcher and clinician. And of course, when he went to Hopkins, we weren't about to get a divorce. So, so here we are.
And you still work together today, is that
We do,
right?
absolutely. Yes.
Marvelous. Great. Well, that is a
Yeah.
beautiful match made in heaven. My favorite things are heroic clinician, oncologists, and dogs. It's like the best conversation ever. And again, I have two at my feet. I hope they don't bark or present themselves. But okay, Noah, without further ado, and Dr. Knapp, go ahead and your slides, and then we'll open it up for questions and a robust conversation.
Yeah, thanks a lot, Stephanie. And it's a pleasure to be here with my good friend and colleague, Debbie. As Stephanie mentioned, over the years, we've had a 2-decade now collaboration going. So let me just get confirmation. Are you able to see the title slide? Is that a yes?
Not yet.
Not yet. Let me try to share again. Let's see. No, for me to do. Okay.
Did Noah freeze maybe? Noah may be a little frozen right now, but let's hope he comes back to us. Let's see. I, oh, there it is. Okay. And we hope Noah comes back to us. He probably just had a little frozen moment there. I think Noah's most likely going to return to us. Uh, Elizabeth will share her screen. We might need to get in touch with Noah. Let's see. I'm sure he's trying to get, it's clearly it kicked me out trying to reconnect. He's coming. He's coming back. He'll be back in a second, everybody. If Dr. Knapp, if you want to unmute, I do have a question for you.
Sure.
It's on the canine side. So in your practice, do you see quite a lot of bladder cancer in dogs?
We do at Purdue. because we have actually a canine bladder cancer clinic. It's
Oh,
not,
no kidding.
it's not
Wow.
the most common cancer in dogs. It only makes up about 2%, but there are somewhere between 2 and 4 million new canine cancer cases a year. So that means even at 2%, there are 40,000 cases around the country. But we we have a special clinic for this. So we see, anywhere from 10 to 20 appointments every Monday. We do cystoscopies on Tuesdays, see cases other days of the week as needed. But yeah, there's a lot of it out there.
It may be part of your talk, but well, so how would you know as a dog lover and owner of two dogs at the moment, how would you know that your dog has bladder cancer? What you may
The,
be mentioning that and maybe repeating it again, but um,
well, the most common things pet owners notice are blood in the urine, straining
okay.
to urinate, accidents in the house. And it's important to realize that 95 times out of 100, if you see those symptoms, it's going to be a urinary tract infection. So when you go, if it's not an infection or an infection that doesn't clear, keeps coming back, then you go look for stones and tumors. So it's usually going to be middle-aged to older dogs,
Mhm.
certain breeds that are very high risk. So your suspicion goes up in those. But um, I have to tell the Purdue students, even though if they hang out with us in clinics all day on a Monday, I'd say you're going to be getting tunnel vision here. If you see those signs, go look for the infection and treat that.
Mhm. Wow. So just like people, blood in the urine is how it manifests. And you mentioned 20 to 40,000 cases a year.
That's
That's
estimated, yeah. Because
yeah.
if they're, they used to say as many as 6 million canine cancer cases a year. I really think that's an overestimate. Now the estimate's at 4, and I honestly think that's a little bit high. Um, but if you look at if it's even 2 million, 2% of that's 40,000 cases. A lot of those go undiagnosed. Um, they're not observed or not pursued. Um, so there's plenty of room to improve what we do for sure.
So if you suspect that your older dog has urine, I mean, all older dogs sort of have urinary problems. I mean, it might not be top of mind to think, oh, they have bladder cancer. It may be that they're just really old. I have a 13-year-old at the
Sure.
moment.
Yep.
And she's super healthy otherwise. And Noah's joining us again. Do you have to, the cystoscopy is hard for humans. I imagine it's pretty hard for dogs too. Is it? No, we've been pinch hitting while you're gone. You're back with us. One second.
Okay.
For the cystoscopy in the dog, do you have to give
Oh
it
yeah.
anesthesia?
Yeah, they're under anesthesia. So it
Okay.
honestly isn't that, it's not that difficult for the dogs because they're
Okay.
completely asleep for the whole thing. And pet owners tell us for about a day they'll be a little more tired than usual, a little more
Uh-huh.
blood in the urine, but that's about it. So
Well,
but
we just learned something. Maybe maybe humans are jealous that the dogs get such
sure,
royal
yeah,
treatment because
sure.
it's really hard. Um, Noah, thank you for joining us again. All these glitches happen, and the slides are yours, and the floor is yours. And I'll just put myself on mute here.
All right. So I think what I'm going to do is I'm just going to tell you to advance slides because I think it might be some kind of connection issue. Is that what Elizabeth was saying there in the chat? I'm just going to do it, Elizabeth. Then you advance the slides for me, okay?
Sounds wonderful.
Okay. Well, thanks for everybody for waiting. Hopefully this will go okay. There's only about 10 slides. We could almost talk through it anyway, but I wanted to kind of just give a little bit of context for why we are interested and have been studying, bladder cancer in dogs. Debbie, myself is a collaboration, but really the whole rest of the veterinary oncology world, has been doing this for quite some time and for good reason. Next slide. So, yeah, can you advance the slide once? Perfect. So as Debbie had kind of mentioned in the intro, there are a lot of similarities between human urothelial cancer and urothelial cancer in dogs or canines. And just a couple of them are outlined here. One is the age of onset and symptoms. So in humans, we often, will quote that the average age of diagnosis of bladder cancer is somewhere around the early to mid 70s. In dogs, it also tends to be a disease that is later in life. Now, in dogs, the life expectancy and life cycle is accelerated. So that can have actually some advantages for us, from a research standpoint, which Debbie and I may talk about a little bit as we get into the discussion portion. Similar to humans, when bladder cancer and urothelial cancer in dogs spreads, it has a tendency and a predilection to go to sites of local lymph nodes, local extension, and then often to the lungs and sometimes bone. It can go to many, many areas just like human bladder cancer can, but its patterns of metastases are very similar to humans. And then in the upper right here, when you look at some of the slides, when you just look at these cancers under the microscope, you can see very similar patterns from a histologic standpoint as far as the urothelial cancer goes. Most of the bladder cancers in dogs tends to be high grade, but there is some heterogeneity just like there is in humans. And then treatment responses. Debbie outlined sort of the experience with anti-inflammatories that got her, into focusing on bladder cancer in dogs. But similar to humans, bladder cancer in dogs also responds to some chemotherapy medicines, some of which we know very well in humans, like platinum and cisplatin. For different reasons, it may not be quite as tolerable or feasible to give an intensive schedule like that in dogs, but the pattern of response, again, gives us a clue that, hey, there might be some similarities here. And then molecular features, I'll just kind of leave that as it is for now, but to let you know that we have been studying this with Debbie on the human and canine side as these technologies have emerged. And we're learning that at a very basic molecular level. There are also some striking similarities and then some very interesting and potentially opportunities where there are some differences between the two species. Next slide. So how do we diagnose and approach, bladder cancer in dogs? Well, as Debbie mentioned, in our initial experience of collaborating on a clinical trial, I got to learn a whole lot more about bladder cancer in dogs than I ever knew. And I was fascinated by how much is available and done in the standard of practice at tertiary centers and veterinary schools that practice oncology, like where Debbie is at Purdue and other centers. The first slide, which you don't need to go back to, just showed how we do cystoscopies in humans. But from a radiology standpoint, pretty much every technology that we have in humans, there is a counterpart in dogs. So just shown here are just traditional X-rays, ultrasounds down in the lower left, and then CT scans in the lower right, which if you look at that CT scan in the lower right, that really looks like a human scan. And also even PET scan, PET tracer technology is also sort of available in dogs. So it really allows us to study the disease staging and response to therapy at a really granular level that is possible in smaller, animal models like mice, but not nearly to this level. Next slide. So one of the other things about bladder cancer or urothelial cancer in dogs that has been fascinating to both Debbie, myself, Elaine Ostrander, others at the NCI over the years is that there are certain breeds of dogs that have a much, much higher risk of developing bladder cancer than other dogs. And this is a situation where we can actually, take advantage of that fact that may be able to inform us about risk in particular breeds. And highlighted by the star is the Scottish Terrier in the left. Scottish Terriers are the breed that is at the highest sort of risk, but all terriers actually are at an increased risk compared to other dogs. And I will let Debbie sort of talk about that in a little bit more detail. But that has presented a really unique opportunity for us to look at and even think about sort of carcinogenesis, or the causes of cancer, and then also genetic predisposition, and really get us to thinking about screening and prevention, which Debbie and her group has actually started, and she can touch a little bit on that. But this presents a model in an accelerated lifespan of 9 to 11 years that is, quite frankly, not possible in humans to actually study the actual initiating factors of cancer, and then potentially think about early detection, and then maybe eventually intervention. Next slide. So that's nice, but why and where in the human, bladder cancer, urothelial cancer standpoint does this collaboration back and forth make the most sense? So I've only got a couple things here that I'm just going to bring back, which we've talked about in other talks in this audience, but shown on this slide is the most recent practice-changing phase 3 trial that brought the drug N-fortumab to the frontline or first treatment for metastatic bladder cancer patients in humans. And this as a result of this trial because compared to traditional platinum chemotherapy, this nearly doubled the overall survival of metastatic patients. And so I highlighted in the green sort of, rectangle on the right, this wasn't taking a survival from 3 months to 6 months. It really took it from 16 months to almost 32 months. And we have never seen that before. And the reason that that's important is that immune therapy or immunotherapy, which we've talked about in this audience before, had become a part of human bladder cancer, treatment for advanced patients. But this trial solidified that immune therapy is always going to be a part of the therapy for patients with human bladder cancer in the metastatic setting, and may move even earlier with some trials that are coming. So that for us, from a model standpoint and thinking about how do we study it, it really ups the ante on our need for animal models that have intact functional immune systems. And our traditional model of looking at a mouse with a suppressed immune system runs into a lot of limitations in terms of thinking about how to develop new therapies. Next slide. Also, on the human side, I'm not going to get into every little thing here, but this is our molecular understanding on the human side. And this is just one sort of picture from what we've talked about before called the TCGA project, the Cancer Genome Atlas project. And this was an effort led by the National Cancer Institute where we used the most modern technologies at the time, about 10 years ago, to look at sort of the genetic code of human bladder cancers. And what we discovered and are still discovering today is that this is really a mosaic of several different diseases. We can discuss kind of how many, but I think in general, the field would agree that there are probably about 4 or 5 sort of different types of bladder cancer. And even in the 4 or 5, they fall under a broad umbrella of 2 umbrellas of basal and luminal bladder cancers. And so that has given us clues about how human bladder cancers are different, and it has shaped our thought about individualizing treatments. Next slide. So from the treatment standpoint on the human side, we have seen a revolution of new therapies come through in the last 9 to 10 years that we have never seen before. And most of these therapies are now directed at very specific targets, either on the cancer cell or in the immune cells that surround it. And I just put a couple of these drugs that are now approved by the FDA as standards of care for human bladder cancer, and then the targets underneath them of what they are aimed at. And so these include antibody drug conjugates, like enfortumab on the left. It includes immune therapy medications like pembrolizumab, also known as Keytruda. It also includes two new therapies that are designed at specific genes that are turned on or off in human bladder cancer. One is called erdafitinib or balversa, which targets FGFR, a gene that's commonly turned on in bladder cancers in human. And then more recently in the last year, there's a drug that is called Enhertu. And this is a drug that targets cancers of all types, including bladder, that have the gene HER2 expressed at a high level on its surface. We know about HER2 most commonly on the human side for breast and ovarian cancer and gastric cancer, but it is now actually a part of the human bladder cancer treatments. Next slide. And then the last thing about the human bladder cancer side that I'll kind of mention is, because we've got more therapies now for our patients, which is a great thing, we've got to understand a little bit better how to give the right treatment to the right patient. And this is just a simple slide looking at one of those platforms that is looking at measuring fragments of a patient's tumor DNA in the bloodstream, what is called ctDNA, and then actually looking to see which patients benefit for this. On the far right is the results of how long patients lived. The dark blue and dark red that are highlighted show that in patients who had DNA, ctDNA detectable, they actually benefit in order to better tailor our therapy to the right patients. Next slide. So in our collaboration with Debbie and myself over the years, both starting at Indiana and now at Hopkins and with Purdue, we really view the canine bladder cancer as a real opportunity to do several different things. Better using sort of the biology better about who benefit. I touched a little bit on the prevention side. Understanding the genetic risks of these cancers and being able to detect and prevent can really help us. It can allow us an accelerated timeline for new drug discovery. Things that we may not have seen on the human side yet, we might identify initially on the canine side and go back and forth. And then I think as the am I back? I think I'm back. I got kicked out there. We're just going to wrap it up here. The next slide is the last one. And this is just two examples of what we've done, and I'm going to let Debbie talk about this, but we have actually performed some of these genetic analyses on bladder cancers in dogs. And this is where I touched on, we're seeing a similar picture of kind of basal and luminal genes. The very last slide is actually looking at a new therapy in dogs that Debbie and her group are leading, that they have published initially the last couple years, but are developing an actual immune therapy for dogs, looking at sort of these checkpoint inhibitors, PD-1 inhibitors. So I will stop there, and hopefully this internet connection will be a little more stable as the slides are not occupying memory space. But I'd like to stop there and invite Stephanie back. And Debbie, I'd like to kind of give you a little bit of a second just to touch on any of the aspects of your vast experience on the canine side that maybe I didn't do due diligence there with that overview.
Thanks, Noah. I think you did a great job. Sorry we kept kicking you out, but yeah, I think Noah described this canine bladder cancer very well. It's a disease. When we first started studying it in dogs, it was considered a disease of no hope. There weren't any drugs that anyone knew that worked. Our approach was go in surgically, do what we could, but that usually didn't help a whole lot. Now it's a disease where I can tell pet owners that there's a 80% chance or more that we can buy their dog months to a year or more of good quality life. We still don't cure it often enough, but we're buying quality life, and there are some dogs that don't relapse. We don't do cystectomies. It's a big time surgery. It's a lot to ask a dog to undergo. And plus in dogs, a lot of the times the cancer has traveled down the urethra, the tube that goes from the bladder to the outside. So that means if we did a cystectomy, it wouldn't be curative. And so we rely on drugs mostly to control it and buy quality of life. If I had to say the three things I'm most excited about right now in the work we're doing, taking advantage of breeds for early detection, early intervention. We did a study in 120 Scotties and found cancer in 40 before they had any outward evidence there was anything wrong with them. And then when we intervene at that level of the early cancer, they do much better. That's something we're already encouraging pet owners to do. If they have dogs in high-risk breeds, get them screened. We'd start at probably age 6, screen them every couple of, maybe twice a year, and then if they're worrisome things, get cystoscopy done and figure out what's going on. The second thing, which is one Noah touched on, is the immunotherapy. We're doing an immunotherapy trial with a drug called a PD-L1 monoclonal antibody made for dogs. And we're doing it for a lot of reasons. One, we want to help dogs. Two is we want to learn things for why does it work when it works and why does it not work when it fails, and compare what we can learn from dogs to what Noah's learning from humans to see if across a species we can come up with predictors for who is most likely going to benefit. Or if someone's not going to benefit, then they'd be best suited being treated with something else. And then the third, which ties into this, is computational modeling, and in that we on many levels are pretty good at predicting how groups of dogs or groups of people might respond, but we're not very good at the individual level. And so we're developing, Nadia Landman at Purdue is leading this work to develop in silico, i.e. models you do on the computer where you feed in all types of clinical and omic data to figure out how do we know what the cancer is going to do in the individual. So, I am optimistic that we are poised to make really big strides in this. But it's, there's a lot of work involved. And again, we're just really grateful to work with the Johns Hopkins team.
Wow. I have some questions, Debbie and Noah, if you will allow me, on the canine front. So you mentioned screening, and you mentioned that dogs present with blood in the urine if you can see it, when you take your dog out for a walk, or, it's manifesting that something's up, that they're urinating too much or having accidents in the house, etc. Is it a simple urine test, or what is the screening tool for dogs?
So our screening approach has been an ultrasound exam of the whole urinary tract and do a urinalysis with a urine sediment exam. That's been our approach. There are some molecular tests out there as well. They have issues with false positives and false negatives. So we're most comfortable relying on the more standard techniques. And then if we start to see changes on ultrasound or we see atypical cells in the urine, then our approach is to line them up for a cystoscopy.
Got it. For a vet anywhere in the country, not specialized in oncology, would they have those tools available? If, ultrasound in veterinary practices and urinalysis, is that common or standard, or would they have to go someplace special?
Yeah, pretty much all practices can do UAs with sediment exams, and most now have ultrasound equipment. But even if a practice doesn't have it, there's a really good chance someone nearby does. It's becoming closer to a standard of care instrument in vet med.
Mhm.
Then the cystoscopy equipment, that's where you need to go to a specialist, because that equipment's so expensive that primary care veterinarians typically can't afford to have that in their practice.
And I would just add that the screening study that Debbie and her group has done so far, where they identified early tumors in about 25-30% of the dogs that were studied, that's amazing to me as a human bladder cancer, provider, because most screening tests that we do on the human side, find a much, much smaller percentage, of patients, even in high risk patients. So I'm super thrilled about that. There's a little bit differences in maybe the type of cancers that we detect, but I think what we're going to learn from that may better inform us about how to think about and maybe have successful screening on the human side. I mean, it's on the human side, you could say somewhat simple to focus on high risk groups like patients with super high smoking histories. But even that, that there's a lot of people that have a high smoking history. So how do we actually conduct, a screening or prevention study, successfully? So I think it's the first step, but I'm super excited about what Debbie and her group is doing.
No, would that mean earlier screening where there's no sort of in a human
Well,
with
there
maybe
is
a
no
high?
screening right now in humans. I mean, the screening right now in humans is your primary care physician doing a once a year urinalysis just because it's what they're told to do. And if you happen to have microscopic blood, show up on the urinalysis, then you may get referred to urology. Or the screening is you actually have blood in your urine that you see. And so that's not, we pick up a lot of early stage bladder cancers, but in many of the bladder cancers that we detect on the human side, may not be lethal. They might be lower grade, be managed. But we don't know. We don't know on the high grade ones, is there an opportunity for us to maybe decrease that burden and, the amount of patients that we eventually lose due to advanced disease if we had a better screening test. And lots going on the human side, a lot of it on the molecular side, which, there's a lot of promise, but we definitely have room for improvement.
A
And if I
question,
could,
Deb.
I
Oh,
was,
please go ahead. Please
I
go
was going
ahead.
to say on the dog side, Scotties have a 20-fold higher risk than other breeds. And so we do recommend screening the other dogs Noah had on his slide, but you're going to have to screen more of those to find it. So like the other breeds, the Westies, Shelties, Terriers, they have like a 3 to 5-fold higher risk. So you're going to have to screen essentially 4 times as many dogs to find the same amount of cancer. And if we screened all dogs, that would be akin to what Noah says about screening people. So if you screen all dogs, knowing that bladder cancer isn't common, you'd have to screen like 1,000 dogs to find 5 cases. So yeah.
How did you happen to recognize that Scottish Terriers in particular have this uh, mutation, I suppose, or why Scottish Terriers or
My,
Terrier?
my colleague Larry Glickman gets credit for that. He's a veterinary epidemiologist, and he looked at databases that have veterinary teaching hospital records and looked at those dogs that had bladder cancer versus those that didn't across breeds, and was able to find that high level of risk. And then the Scottish Terrier Club of America confirmed it with a breed survey.
Oh, fascinating. Wow. That's really, really interesting. I have a very odd question I've always wanted to ask. The other day, someone came over and they were twins. They were boy and girl, not identical, but clearly they were twins. In a dog litter, which can be many, my Dalmatians one Dalmatian was one of 13, if you can wrap your head around that. Are dogs in utero when they're, you know, in the womb, big litters? Dalmatians always have big litters. Are they technically twins, and do they share the same genetics? And is that a valuable resource for looking at outcomes? Why would one in a litter get bladder cancer and one maybe not? Is that, am I crazy to think that? Or
No,
um,
you're not crazy at all. And we and others have and are continuing to try to do what's called pedigree analyses, where you track every dog in a litter. We haven't had great success yet because the litter gets dispersed so much. But in the litter, they're not the same as identical twins in people. They would be the same as a non-identical twin. So they share genetic features, but they're not clones of each other. But you can still learn a lot, because if you can study, say, 20 litters, and you know within the litter who gets cancer and who doesn't, and you have their germline DNA, then you can figure out some of the causative risks for this.
That's really important. I'm thinking
Yeah,
a
absolutely.
household, one dog goes to a household, say with secondhand smoke, one
Right.
goes to a farm with pesticides or, whatever.
I
I'm not
don't, I
indicting
don't know
anything,
this,
but
Debbie, but particularly among like the pure breeds, and the breeders, when dogs are born, do they have any newborn genetic screenings where there would be germline available for some of those dogs?
The Scottish Terrier Club of America is banking blood from Scotties now.
Yeah.
I don't know how long it will take them to accumulate good numbers, and what the challenge is going to be in getting good follow-up over a period of
Yeah, yeah.
years. But there's not, the closest in Scotties, they get a condition called Scotty cramp, which causes them to have muscle contractions and intermittent lameness. But that doesn't seem to be associated with bladder cancer. But there should be germline DNA sitting around from those dogs. Yeah, that's a great question. And the Ostrander lab's also trying to accumulate samples on this as well.
to the immunotherapy discoveries and commonalities, is the immunotherapy for humans the same as in canines, maybe a smaller dose? Are they used enfortumab vedotin has been a real amazing discovery, as I understand it, very positive discovery. Would that be administered in dogs or not yet?
Well, I'll take
Go
a
ahead, Noah.
stab at the human side. I mean, I I think drugs like enfortumab and the Enhertu that are in a class of drugs on the human side called antibody drug conjugates, um, the technology is there where they could be made on the canine side, but the targets might be different. So, for instance, with enfortumab on the human side, it tries to anchor to a target on the human bladder cancer called Nectin-4. And that may or may not be as ubiquitous in the canine side, but there may be other targets. So I know, Debbie, you had been involved with, like some folate receptor, work in past years. But the challenge of making an antibody drug conjugate is not a small task in terms of the chemistry of putting together the target, the chemo, the linker. So I don't know, Debbie, if you can speak to that on the canine side, if you're seeing antibody drug conjugates, not just in, canine bladder cancer, but how you're seeing that in the cancer canine world.
We're not we're not as far ahead as you all are on humans. We know some of the targets. We haven't developed antibody drug conjugates yet, but like you mentioned, Nectin-4, sometimes in dogs we see more Nectin-2 than Nectin-4. So we would need to develop a drug aimed at that. And plus, antibodies have to be designed for the species they're going into. Like, we can't take a drug, an antibody drug developed for people, and give it to dogs, because there's a really good chance the dog protein would differ just enough that it could cause an anaphylactic reaction.
Oh.
So for the drug we're using, we had to engineer it to look like dog in order to be able to give it to dogs without them rejecting it. But yeah, I am super excited about the enfortumab. That's all the more reason we need to do some catching up in veterinary medicine, because the potential for those is just huge.
We have some questions in the chat, and I hope I do this justice to Bess and Harry. And the question is, what about research on NIH or NCBI regarding Chinese herbs that may trigger bladder cancer cell apoptosis. Am I using the right word? And using the same mechanism in dogs and or humans. So I think the question relates to Chinese herbs.
Yeah, I think it's actually there's two parts to that question. I think the second one was they mentioned that was the study was conducted in mice in terms of their initial studies, and I think they were saying that it was causing bladder cancer cell death, the apoptosis from the administration of these agents. Yeah, I'm all for it, but I think we're all for studying any any potential early compounds that show activity. I think there is an entire branch, at the NIH NCI looking at sort of medicinal products and herb supplements and cancer screening as a high throughput drug screen. I think our challenge with a lot of the medicinal herbal products, at least in the United States, to be honest about bringing them forward, it's difficult for us to get consistency of manufacturing and see it viewed sort of as a drug and a therapeutic the same way that some of the other cancer drugs are in terms of the quality control that is needed. And so I think because of that, many of the herbal supplements that may have activity against bladder cancer and others haven't been studied maybe as deeply and as meticulously as they need to be. But there's certainly interest there.
Right. Another question from our friend and colleague, Karen Sachs. Do dogs have similar gene tumor markers to humans?
If you look at the genetic markers in the cancer itself, they're very similar to the genetic markers in human bladder cancer. They're not identical, but there's a lot of crossover. So a lot of similarities.
Great. And then our friend Pam asks about the cost of care. Cancer cures, prevention, therapeutics are expensive. Assuming ongoing care will be necessary with a local vet, will a local vet be able to provide treatment is the first question. And what is the cost of care? Is it very expensive for dog owners to afford bladder cancer care? And what are the top breeds that are at a higher risk? I think we want you just to repeat what that slide said before.
When I talk to dog owners, I tell them there are three broad options for treatment. They can be conservative with palliation with a non-steroidal anti-inflammatory drug. And that buys on average 6 to 7 months of good quality life. If they want to do more or have the capabilities to do more and add in IV chemo, then and I'm giving you what I call average survivals. It's like the middle dog in the whole spectrum, or median. And so then the survival goes up to more like 10 months. And the dogs that benefit the most get more than one treatment over their lifetime. So you use something as long as it works. And then if it doesn't work, then you do something else. The third category is going clinical trials. So treatment-wise, our prices are probably considerably less than private practices, but we could do the conservative option. The drug itself, it would be less than $100 a month. The monitoring is going to add a couple $100 on top of that or more. The IV chemo route at our prices, pet owners are spending about $1,200 a month. And then the clinical trial, if it's funded like we really try to get ours funded, then the pet owner pays far less because it's subsidized. But primary care veterinarians could absolutely do palliative care. Some veterinarians are comfortable handling chemotherapy and others are not. So it's really their preference whether they want to do it. But there are lots of options. So, I mean, the palliative care option's not bad at all, honestly.
Is there such a thing as BCG for dogs?
No. If we were to use it, we'd use the human product. The dog tumors tend to be higher grade and thicker. And so intravesical isn't as effective. And plus, the dog tumors tend to be so vascular that what we put in the bladder can go in the bloodstream really easily. And you don't really want BCG going throughout the body. So we don't tend to do that.
And I imagine radiation is not even an option, or is it?
It is an option, yes. I wish we knew more about the optimal protocols. There's some veterinary oncologists think you're undertreating if you don't do it. There are others that think it's an option. We think it's an option, but we wish we knew more about it, how to do it most effectively.
And
Noah,
I
I
would
keep
just
cutting
add,
you off.
I would just add that one of the things that I learned in working with Debbie about clinical trials in dogs is the cost issue. And, if we're able to get, a grant or an industry sponsor to offset some of the costs in terms of the treatment for the investigational agent or some of the monitoring, it actually can be cheaper for the pet owner to be in a clinical trial. And at least our experience, they tend to accrue pretty well. Both the pet owners are very motivated to, get good care for their dogs, but also there is an actual financial advantage to being in a trial. And that's a little bit different, I think on the human side, where we think about just sort of like the time and, the extra testing and things, which is unique to the canine side.
Debbie, for you, an awkward question. Sadly, every time my dog has a birthday, I cry because their life goes by so fast, and we don't want them. We want time to stand still. But given that in a trial, um, do you learn of outcomes much more quickly because it's a compressed time frame and their lifespan is just shorter than, it's not 70, it may be 15. How does that work in terms of discovery and what you're learning? In and what benefit does that have as it relates to humans?
We definitely learn more because of the compressed lifespan, and because unfortunately our therapies aren't as effective. So so the bar isn't as high as it is in people to show that something's really beneficial. I think where the compressed lifespan helps us the most is in early detection, early intervention, because we can study a period that would be 10 to 15 years in people. We can study that in 2 to 3 years in dogs. So I think that's where we really have an advantage. But yes, the trials, even the treatment trials of advanced disease, are compressed because the longevity at that point isn't that long.
What just in general, fascinating, what is considered early detection? Like, is it a dog, say a larger dog that's, well, say a Scottish Terrier that's a smaller, is it age 3 is early detection? Is it age 4? Is it at what point would you start sort of thinking, well, this breed is susceptible and maybe I should have it screened? Around what age would that be because of this shortened lifespan?
So we would, based on what we know in Scotties, we'd start about age 6.
Okay.
Because we were going to start at age 7. And then once we started screening, there were 6-year-olds that we were finding with cancer. So we said, okay, let's back it up to age 6. The 6-month interval appears appropriate because there weren't any dogs that were tumor free at one visit and then 6 months later had advanced cancer. We defined the early detection as much, though, by the stage of the disease, because we were finding very small tumors on ultrasound, like less than a third of an inch. Whereas when dogs walk in our door because they already have trouble urinating, I mean, their tumors can, I think the average is like 5 centimeters, which is a couple of inches.
Okay.
So we really do find it early,
I
and they
have
respond better.
a closing question. How has it been to work together on this project? I mean, there's the canine part and there's a human part, and then the intersection of your work. Clearly, it's informed both of your worlds and brings up a lot of ideas and questions and maybe sort of thoughts about how to move forward. The field, I looked it up, started only in 2003 that the NCI got involved. Do you see this as a field that will continue expanding? And I'm sure it's not just limited to dogs. I'm sure it's all species. Is that right? And so what does the future look like for bladder cancer in dogs, you working together, and the whole field of comparative oncology as it relates to maybe making life better for our dogs and our humans?
Now, what do you want to start? Or you want me to start?
Yeah, I mean, I I think it will continue to expand. And I think with immune therapy kind of here to stay, for the next 25, 30 years, our need for animal models that have intact functional immune system is greater now than ever. It doesn't mean that the mouse models go away, but our need to actually study naturally occurring cancers that can mimic sometimes the environment and also kind of some of the heterogeneity within tumors. There's a real need there. And I think there's a real opportunity, not just for discovery, but for therapy development. And what really drives the engine, I actually think there's a commercial angle there for companies to actually invest and build up in some of their comparative oncology sort of investments.
Interesting.
Yeah.
And my take is it's been fantastic to be able to work with people on the human side. I'm a veterinarian. I love animals. I would do what I do solely for the sake of animals. But my whole career, even debating whether to go to vet school or med school, there was always this thought in my head, I'd really like to help humans too. And so this has really been just a very rewarding experience. And I hope it just takes off from here, the field that is. There are going to be alternative funding models, I'm sure of that, but I think there are going to be new opportunities to fund this work that weren't there before. And so I'm pretty optimistic, honestly.
Well, thank you both for this really fascinating conversation. I have personally learned a lot, and also it just opens up a lot of thought and doors, and also the thought that you've been doing this for over 30 years, and it is value. It has value and will continue to have value for, yes, our humans, which we are here for, and that's why we have a Bladder Cancer Institute, but also for our beloved pets who sadly also get bladder cancer. So thank you all. This has been fantastic. I hope you still keep collaborating. We would love to have you back for some updates. And thank you just for a wonderful, wonderful session. It's been terrific. Thank you all for tuning in. Remember, folks, if you have a question, bladdercancer@jhmi.edu, we'll answer it. And our next session, which will not be about dogs, sadly, but will be about BCG and its alternatives as we continue our series, is on May 20th, and the women's program is on May 7th. So thank you all. Happy Easter and have a wonderful night. If you have a dog at home, give it a big hug for us. And Noah, thank you. And Dr. Knapp, there are no words. You're fantastic. It was a great session. Thanks again, everyone.
You really enjoyed participating.
You bet.
Thank you. Bye-bye.